Welcome to the latest in our series of TopMedTalks 2. In these podcasts, the TopMedTalk team is in conversation with global thought leaders in perioperative care. TopMedTalk.
Hi, this is Korey Springman, and I'm here with TopMedTalk, speaking with Dr. William Wooden from the Indiana University of Health, or IUH, in Indianapolis. He's the Director of Surgical Quality and Wellness, and he's here to talk to us about nutrition.
Well, thank you very much for having me. It's an exciting new look at how we should be doing things.
Absolutely. It's something that we all should be really excited and passionate about.
Well, it's true. It's, if we think about, we've always tried to deliver good health care. The Hippocratic Oath drives us. But unfortunately, the complexity of turning health care into medicine and the regulatory aspects and other issues often detract us from what we'd really like to be doing is optimizing the care for each patient. And I think the whole concept of the ACER Society, as well as the recognizing the importance of preoperative wellness and wellness in general, really will help us get back to that patient. It will also provide us a real way to better organize all of our healthcare providers. So our nursing staff, physical therapists, respiratory therapists, pharmacy, bringing back an enthusiasm for healthcare as opposed to just the drudgery of a job with heavy administration and limitations instead of positive expectations. Let's bring back the positive expectations of really providing quality care that will cost society dramatically less and improve lives.
Right, absolutely. Nutrition's important to all of us. It's most important too, especially when we're ill, cancer, having surgery, any type of stress on the body. Our nutritional status is super important, and it's something that is so simple, but gives you a huge impact and outcomes.
Well, it really is. We actually see patients with scurvy, beriberi, pellagra, things that we thought were dead diseases, but they actually exist in our society because of our very poor nutritional habits, but also we have to deal with nutritional deserts within our community. Some patients, some families, either by habit or by circumstance, either cannot access or don't access basic good nutrition. Processed foods are wonderfully fast, efficient, but not always the nutrition that we need. And one of the things we've recognized is when we look at really improving quality at the hospital level is patients come to us with a lot of, unfortunately, bad habits, but also poor health. That's why they're at the hospital. If we look at it from a nutritional standpoint, this really gives us a real opportunity to, one, improve that patient's health and outcome, and then to reset their health and outcome for when they go home. So working with that patient, working with the family, hope will then be very contagious, and I like to be contagious with enthusiasm, to then get people to change in a positive way. Show them how well they can change their lives and how much better they can feel with some simple things, getting up and moving, some a little bit better nutrition, and getting them to recognize that good nutrition is not expensive. A lot of people have misconceptions that good nutrition is expensive. No, actually it's cheaper than fast food. So those are important things. And one of the things we've done in Indiana is we very much believe in the enhanced recovery processes. We also recognize that there were some real deficits in basic things that we can implement. And one of those was immunonutrition.
So let me pause you right there. So tell us a little bit about your background.
Yeah, so my background is I was general surgery trained and then surgical oncology and microsurgery trained and then plastic surgery trained. And my whole career has been based on basically dealing with those more complex reconstructive challenges. So for the patients that have had operative complications due to other processes, trauma, cancer, congenital abnormalities, I've really enjoyed that more complex reconstruction. So with that, I'm constantly faced with people who have not had the best of outcomes. And what I recognized very early is many of those adverse outcomes were due to very poor nutrition. Poor nutrition before they had the event or then afterwards. It's often very difficult to feed a patient who is ill, sick, or has trying to recover from a trauma. Things don't work. And so then how do we make sure that your body gets the fuel it needs? If you think about our bodies as an engine, and it's a wonderful machine, but it has to have all the right things. We have to be able to oxygenate. We need to have to be able to deliver things to our cells. So we need circulation. And then we need the building blocks of recovery. And those are your nutrition. So your micronutrients, your proteins, on all those things that let us really recover from an illness or injury.
So within your health system, we have to have some baseline data to help drive what we want to implement, as well as the change in our outcomes. Tell us a little bit about that.
Yeah, so when we looked at our patients, we recognized that, one, we had a real opportunity to do better. The other thing is we looked at the data. We identified that 75% of the patients that presented to our hospital had 3 or more risk factors for a complication that were going undermanaged or unmanaged. And this is where we really get to our deficits in population health. Our primary care provisions are working exceedingly hard, but we've not been able to develop processes to help them to make their job easier or to better educate patients and providers on really the healthcare deficits in their community. So we recognized that we needed an easy button to help deal with those patients coming in. So we really looked to change the way we assessed patients when they came to the hospital, and then have some very rapid interventions to address their nutrition, their immune state, and their overall health, so we got better outcomes.
So, Monty Wythen, he always says, perioperative medicine starts when the contemplation of surgery occurs. So at what point are you able to screen your patients and then recognize patients that are at risk for malnutrition and poor outcomes to then implement your change?
Well, he's exactly right. And so the first place that we can actually catch the patient is at that first contact. So as the patient is referred to a specialist for intervention, that's a little bit different than how we've looked at population health, where we were trying to drive things heavily at the primary care level. That's a great level, but they need help. They need our help and to work synergistically. And so once that patient is referred to a surgeon, a cardiologist, a pulmonologist, an infectious disease provider, that needs to be that contact to then begin the assessment, validation, and optimization process. For the referral to the surgeon, as soon as they get that referral, we need to immediately begin educating the referring provider, but also the patient and family as to the things they can immediately do to improve their health and to improve their recovery. What's exciting is patients are more ready for this than I think physicians. As patients, society, we are overwhelmed on a daily basis on nutrition ads, health ads, all things. And the thing we need to do is help them separate reality from fad. And so that's where evidence-based really becomes in. So how we help them identify what are the simple, direct, evidence-based things they can change in their life that we can help them with and help their providers or physicians with to give them better health and outcome.
So how do you guys do this? So
we basically have put together a program that we progressively gauged in acceptance with our providers, which is sometimes an uphill battle, but getting everyone to get on board. And so the nurses in the office, the nurses in the clinics, the physicians when they come to clinic are prepared to have that initial discussion with the patient. Mrs. X, you may not be as healthy as you need to be. We're going to help improve your health so we get a better outcome. So you can fight your disease and recover better than you would otherwise.
It takes time to really educate patients as well as champion them and excite them. Do you guys provide time for physicians to sit down with the patients? It's hard, but I can tell you can do a great deal in 90 seconds. I'm going to take Mrs. Jones as an example. Mrs. Jones, we're going to need to deal with your cancer. That's really important. But there's some things that we can do to help you, one, fight your cancer and help you recover from the therapies we need, specifically surgery. We need you to get up and move. We need you to fight the bacteria on your skin. We need to help you stop smoking if you smoke. And we need to address your nutrition. Those are key things they all recognize. Drive those home. Then likewise, we have a program that will restore your immune system, and everybody's prepared about immune health because they hear the ads all the time. But we now have evidence-based products that we can actually use to stimulate your immune system to help you heal and fight your cancer. Those are things that we're going to help do before you, and we need you to engage, and my nurse is going to spend some more time with you. So, 90 seconds, the physician drives home the identification, the process, and the tools and the importance, and then you pass that off to the nurse and the MA in the clinic. So now, in combination, you've got that started. Then when we send them to our preoperative testing area, likewise, the nursing staff reinforces that, and then they get a phone call before the surgery, which is that third. So it's kind of like when we learn to school. Tell you what we're going to need to know, tell them, and then reinforce it. The other thing is we've recognized that even with that, compliance is a real issue.
It's hard for any of us to remember what we're told at our doctor's office or any other important meeting that we go to. And so with that, we're looking to some very fun, technology-driven texting processes that will allow us to directly communicate pathways. And I think that's one of the key things enhanced recovery is really driven around is pathways of proven effectiveness. And so now we can be able to remind patients, did you get up and move today? Did you eat well? Did you have a healthy snack? Did you take your medicines? Have you started your Impact AR immunonutrition program? So what it is, and so regardless of what you're going to have done, very simple short snippets that from the time of decision to surgery to the time they come to surgery, but then also continue it afterwards and work with nursing. So it's time for you to breathe. It's time for you to use your incentive spirometer. It's time to wiggle your feet. Those are all things. And then when, especially like for total joints, it's time for you to do your knee exercises or your back exercises. Those are real simple little prompts that we can use to engage the patient and their caregivers on the front end, during the time of surgery, and then afterwards.
Absolutely. So tell us about your outcomes. After your implementation, what were the key factors that you implemented and the outcomes that came with it?
Well, the key factors are kind of the things that I've touched on. Improving activity, overall nutrition, smoking cessation, and then nutrition and specifically immunonutrition. We chose the Impact AR product due to the evidence-based medicine and the data would say that it would reduce our length of stay by up to 2 to 3 days and reduce surgical site infections by 40 or more %. What we found was it reduced our length of stay by over 50%. And likewise reduced our surgical site infections by over 50%. This is on top of all the other changes that our hospital, as well as every other hospital, is trying to do. Every system is trying to improve care on many facets, but what we found was this really augmented every effort that was all being done elsewhere and actually gave us a 50 to 60% reduction in the key risk factors or what we call harm events. And if you look from 2015 to now, we've been able to reduce our harm events in our system by 78%.
Wow.
That was more than I ever expected. I was hoping for a 10, 20, 30, maybe 40% reduction. We were able to give our patients a 78% reduction. If you think about it, think of the dramatic change and improvement for that individual patient, their family, the reduction in their cost. We've been able to show that reduces the cost per case by $3,000 to $5,000. And then if you reduce that readmission, that saves tens of thousands of dollars.
Absolutely.
It's incredible.
Well, I think that you're doing great, and I hope that we could all champion something like that in all of our institutions, academic, small hospitals, outpatient surgery. Talk to me about your interaction with your administration on this.
Well, administration is always hard because they're charged with keeping the lights on. And with that, they have to have an operational margin, and they're seeing their reimbursements cut just as we are on the physician side. But this is where we really have to get past the three silos. There's a silos of, we have an operational above it, we have revenue stream, and then we actually have revenue. And so historically, administrations have never been able to account revenue, direct or indirect, back to budget. It's just all at the end. So whenever we've had to cut costs, everybody has to take a 5% cut. I think any of us in business or administration have had that talk. At some point we have to cut costs of our business. The problem is, how do you do that effectively? And historically, it's just been the cut. It's not been an evidence-based directed cut. And so this is where we really need to work better and use evidence-based to show administration that yes, by either spending a little or more, we can get a return on investment. We know that for every dollar spent on nutrition, you can return $52.
Wow.
So if you're the CFO and you're looking at an investment, a 1 to 50 ratio is a real one. But they didn't know that. It's our job to enlighten administration and governmental administration on both sides. You've got the local as well as the regional as well as the federal. We have to get them to recognize that healthcare providers are the experts in this. Let us help them come to the solutions. Let us help refine healthcare to live not only under its budget, but recover budget, but then use those recovered dollars to reinvest in health. Help us build better healthcare systems. Help us rebuild our primary care networks. Help us provide nutrition of excellence to our patients that are going to be tomorrow's healthcare consumer. That's the real excitement.
You have a very great mindset and outlook, and it's what we all need to have in medicine, and sometimes it's kind of taken away from us just because of the nature of the work, and just daily life, just trying to take care of everyone as well as ourselves. What is one last thing that you'd like to drive home for us before we wrap up here at ACER?
I think the real thing is I'd like both government as well as administrators and physicians to recognize the power of synergy. Let us work together. Take a minute to actually come to the meetings, or let us bring the information back home from both sides and share it.
That's great.
If we can do that and we can really change education, that's one of the things. We need to bring these new initiatives back to our educational model. So we need to be training our healthcare staff of tomorrow based on current knowledge, not past knowledge. 100%.
And so I think that you're meaning like within our nursing curriculum, within our resident curriculum, within all of our curriculums, even the healthcare administrator curriculums, they should know about how important nutrition is. And it's the sheer basics of human physiology and functioning that really is going to drive outcomes, quality, and overall satisfaction for providers and patients.
Exactly. That's what's really going to change quality, which is going to improve costs, which is going to reduce the overall burden on society and allow us to invest where it'll really make tomorrow's difference.
Well, thank you so much for all of your hard work.
Thank you for being here.
And making this big change.
All right. Take care. Have a great day.
TopMedTalk.
Nick Majerison here. Thank you for listening to TopMedTalk. Now, make sure you've subscribed to TopMedTalk on your podcatcher or however it is that you're listening to us at the moment. And you're spoilt for choice. We're on pretty much every single podcast platform you could think of. So make sure you've subscribed. Make sure you've engaged with us on social media, Twitter, Facebook, LinkedIn, YouTube. And make sure you've signed up for our email updates on topmedtalk.com. If you get yourself there, you'll find a website that contains all of the podcasts that we've ever done, and it gives you the chance to sign up for our email updates. That way we can always get in touch with you and tell you what we're up to. Oh, and while you're online, check out ebpom.org/meetings. While you're there, get excited about EBPOM London 2019, the London Perioperative Medicine Congress. It's on July the 2nd, and it's one of many meetings that EBPOM organises around the world in order to communicate the perioperative medicine message. Have a look, ebpom.org/meetings.